points to start with, which is the CME hours. If you see the slide that was shown earlier by Shuruk, by the end of the session, there will be a link shown to every one of us. You need to answer the questions. This is a survey requested from Department of Health, where you'll be able to answer the question, and then within a few minutes, you should be able to receive your certificate in your email. In case if you have any problems with that, check as well your spam. If not, then you can communicate directly with Shuruk, and she will do everything she can do to help you with. The format for tonight, it will be almost 90 minutes. We will start with the first part discussing different clinical conditions, and we will stop in the middle, so maybe around 45 minutes from now. I would encourage you all, please, to send any questions for our distinguished speakers tonight in the chat box, and then we'll start, we'll choose some of them, we'll discuss it for 5 minutes, and then we'll carry with the second half. I know it's already late. I want to introduce my speakers for tonight, and honestly, I can spend 1 hour just introducing them. So to start with, Professor Dimitri was kind to summarize it very well. So Professor Dimitri Azor is the CEO for 2020 Therapeutics. He is a distinguished professor and BA field chair of ophthalmic research and former dean for the University of Illinois Chicago College of Medicine. He's also an ophthalmic surgeon who has made significant contribution to the pathogenesis and treatment of corneal diseases, and to pioneering advances in refractive surgery. He has served as the key advisor in different ophthalmic projects since 2014. Dimitri completed his residency and fellowship in Harvard. He was a professor there as well, and then he joined the University of Illinois, becoming the head of the ophthalmology department there. He did his medical school, the MD from American University of Beirut, and the MBA from University of Chicago. And I think seriously, Professor Azar is somebody who requires no introduction whatsoever, but it's a courtesy that I need to do. The second speaker as well for tonight, which is a very close friend to all of us here in the UAE, is Dr. Ilyas Jarada. Ilyas is the head of cornea and refractive surgery, the department at Beirut Eye Specialist Hospital in Lebanon. He's a teaching faculty at Lebanese University and in St. Joseph University as well. He as well practicing in UAE as an eye, cornea, and refractive surgeon, specialist in the Mediclinic Dubai Mall, Dubai. And he's a founder, and that they have secretary for the Emirate Society Cornea and Refractive Surgery Club. Ilyas as well, coming from Harvard with 2 fellowships in cornea and refractive surgery. And he published heavily on keratoconus and refractive surgeries. He has his own nomogram as well. I guess most of us are familiar with it. I can go on and on and on, but to respect the time for the presentations, I'm very grateful and thankful for the wonderful 2 speakers that we are having tonight. I'm also thankful for Novartis team for setting up this webinar for tonight. The society welcomes the quality of such speakers, and we are eager to learn from both of you tonight. You can start, Majors.
Thank you so much, Dr. Saleh. I'll be starting here. We're asking Dr. Jaradi, who will be in charge of the slides and a lot of the content here, this will be to work on an interactive session between the 2 of us. We are very close friends. We work together in Boston, and we will be sometimes arguing, which will add life to the presentations, but most of the time we will be in total agreement. We both take the opportunity to thank the Emirate Society of Ophthalmology, and thank you, Dr. Saleh, for this opportunity. Also, our good friend, Dr. David Sullivan, would like to thank him and TIFOS for putting together this program. And this will be the first session of many other sessions that we are going to have from the DEWS 2 report. There'll be other speakers at later time. But today we will start with an overview. Next slide, please. And this slide will show this overview slide. you will see that we were focusing first on the impact on vision, and then we will cover some specific conditions, including but not limited to dry eye. In fact, the focus on dry eye would be very limited today, and because many of the future speakers will be focusing on dry eye. As Dr. Saleh said, we'll have the break after going through the specific conditions, and then Dr. Jaradi will be discussing, and I'll be joining him discussing some management of certain ocular surface disease conditions. We're going to go very fast. I know this material is familiar to everybody, and we start by talking about ocular surface disease and its impact in vision. You can imagine there are 5 reasons why ocular surface disease can affect vision. First, and obviously, as you can see from this picture, irregular corneal disease. In addition, there could be corneal opacities, epithelial surface disease, dry eye, and limbal stem cell deficiency. Next slide, please. This next slide shows a condition of an opacity. Of course, if you have an opacity in the cornea, whether it's subtle or as in slide D, or very obvious as in slide A, the vision is going to be affected, and ocular surface disease will have great impact on vision. Obviously, there are other conditions, including map-dot fingerprint dystrophy, which is shown in the next slide. Next slide, please. And you can see here, this is taken from Dr. Kenyon's a famous article in the book that I have the privilege in editing. And also dry eye disease. You can see how the surface can be, especially put fluorescein on the eye could be injected, etc. A lot of work is going to be discussed later on this. Next, we will move to showing examples of limbal stem cell deficiency, where again patients will have limited vision. And finally, we are going to move from this while we're on the topic of dry eye to discuss the 2 major branches of dry eye. And Dr. Jaradi now will talk about aqueous deficient dry eye, and I'll talk about evaporative dry eye afterwards. Dr. Jaradi.
Well, thank you all for having this invitation. It's a pleasure to be and see you again, Dr. Dimitri, Dr. Saleh, Emirates Society, Novartis, and everyone. And special thanks to Dr. David as well. I would like to add to ocular impact on vision. I would like to add I'm experiencing what I call psychosomatic impact, like a patient with the subconjunctival hemorrhage coming with severe pain and closing his eyes because not seeing well. After reassuring that this is benign condition, it becomes that he's recovering vision. So as well, psychosomatic as well playing a role. Again, to the tear film problem and dry eyes, major compound of the aqueous deficiency. As we know, the aqueous part of the tear film forming a major part of the tear film as well. And this defect, once we have a defect in the secretion of the aqueous part of the tear film, we call the aqueous deficiency, and that might be attributed in part to major part to, as we know, the Sjogren and Sjogren-like disease like rheumatoid arthritis and other systemic disease. All those are autoimmune disease. As well, the non-Sjogren, which are destructive disease of the lacrimal gland. Also, we have the lacrimal gland obstruction. We have the hyposecretion state, which are mainly caused by the decreased reflex from the cornea to the secretory mechanism of the lacrimal gland as well. And we have as well some specific conditions that they cause destruction and hyposecretion of the lacrimal gland. So again, this is the aqueous is characterized by a drop of the aqueous secretion versus the evaporative part, which is normal secretion but evaporation, high evaporation of the tear film. Here I'm just showing one case, I take an opportunity, very rare case of the aqueous deficiency called the SIPA syndrome. This is a patient we have encountered and we published about it. Once we published this case, it was only 52 cases in the literature. The SIPA, congenital insensitivity to pain with anhidrosis, those who do not feel pain at all. Secretion reserve of the aqueous humor, but the reflex, because of the pain and stimulation of the cornea, is absent. And that could reflect as well in ulcer all over the body, because the pain do not feel pain, cannot avoid being hurt. This is very specific condition that as well I'd like to mention about. And here as well.
Yeah, Dr. Jaradi, we had Would you like me to comment about this first? I want to congratulate you on
Yes,
this
please.
report. Clearly very important finding and something people don't pay attention to. This case, of course, when you have congenital anhidrosis, the patients are not going to be feeling, and then there will be the ulcers that they will have not only in the cornea, but other parts of the body as shown in the pictures you are showing. There could be something that we have to pay attention to. So it tells us from this slide, and I think that's the point in your paper, the reason there is aqueous deficiency here is that because there isn't a good reflex arc because the sensation is limited. So it's important in all these patients to do corneal sensation, either with a Cochet-Bonnet aesthesiometer, or if you get a little cotton swab and then try to touch and see if there is loss of sensation. Great case.
As well, I think we shouldn't forget about the primary dry eye, which usually we attribute it to aging effect, hyposecretion. It's very common, I think, as Dr. Saleh agree with me, it's very common in our area. So every other patient come complaining with dry eyes, and this has been very much accentuated with the corona lifestyle. So what do you think, Dr. Dimitri? What happened with the corona lifestyle, people complaining of this computer syndrome, or let's call it the corona life syndrome?
Yeah, I mean, of course, this is unrelated to the case you are showing where it's congenital, but this is another important component. Thank you for asking. The people who are using computers more, there is a suggestion that they're blinking less and they're producing less aqueous, and the incidence of dry eye, there are a few papers in the literature now showing that there is an increased incidence of poor blink because of dry eye. We started a study, AI, on artificial intelligence to study this, and we realized that the blinking rate and the eyelid movement can be affected both ways in dry eye. You can have poor lid movement causing dry eye, but you can have patients who, and then you will see the blink rate to be very low, as you are showing in this slide on the right-hand side in yellow. Or there are others who have dry eye, because their eyes are dry, they have a tendency to compensate by blinking more. And so far, it has been very difficult for us using computer vision to know which is which. As we collect more patients into our studies, we will hopefully be able to differentiate the two and be able to get this as a routine test that would allow better diagnosis of dry eye. In fact, not to miss many patients who may have dry eye.
Do you think corona would affect the sensitivity at the level of the cornea? I have seen quite a good number of patients with corona conjunctivitis. I think would lead as well to kind of neuritis, drop of sensitivity, and drop of secretion. We never know.
I don't know, frankly, but that's a good point. Yeah. So it's a corona infection rather than lifestyle. We have to move on, but I hope the audience has enjoyed this conversation. Moving to the other big entity, which is the evaporative dry eye. And here you all know about meibomian gland disease. We don't want to spend too much time on it. And this will be discussed in future sessions that the TFOS has organized that will come later on. And just from these pictures, you can see that there are meibomian gland attrition. Using an infrared camera, you can get a good diagnosis of this. But before we move to the next slide, the important point is that the reason there is more evaporation in most patients, not in everybody, is that the meibomian glands are not functioning properly. So there is less of the proper oily layer over the aqueous part, and therefore there will be more evaporation. So many of the patients with pure evaporative dry eye have meibomian gland disease. Many who have meibomian gland disease have, as a result of that, more evaporation. Next slide, please. And you can see in this next slide the inspisation of the meibomian glands. These glands are not producing any oil. They're producing butter and toothpaste. And if pressed on them, you're going to have stuff coming out and floating on the surface, rather smoothly covering the surface. And in this particular patient, there's also anterior blepharitis, as you can see from the collarettes on the eyelashes, etc. And often these two conditions are associated. So it's important not to forget the eyelids when you're doing an ocular surface assessment. Of course, everybody here knows that, but it's important to move on for it. So it brings us back to a closure on the dry eye in general, which is this slide from the DUCE 2 report. I was honored to be part of the executive summary writing committee. And you can see, you go through all the diagnostics that you see on the left-hand side. You do all the kinds of tests. I calculated that it may take an hour and a half to do all these tests if you do them the first time. But over time, you could do them very efficiently if an office is equipped to look at all the factors. And what Dr. Jaradi was describing in the aqueous deficient, you will see in blue on the right lower hand corner. And what I just referred to, and Dr. Jenny Craig will be talking at a later session dedicated to this particular slide, maybe an hour, you will see the evaporative dry eye, and you can grade the severity of the meibomian gland disease. And of course, there are patients who have overlap. It is thought that about 2/3 of the patients who have dry eye will also have a meibomian gland disease of either mild, moderate, or severe that is causing additional evaporative problems. And as I said earlier, these are associated with blepharitis. The next slide will show a table, and I think you can divide your blepharitis into anterior, marginal, or blepharodermatitis. These could be infectious and non-infectious. But when we think dry eye, we're not thinking about infections until or unless you have blepharitis. So that's why it's important to also look at the lids, because then you may need antibiotic treatment for this condition, in addition to potentially steroids. The standard treatment has been eyelid hygiene. Next slide, please. Topical antibiotics, topical steroids. And but there are new therapies now, such as the mechanical approaches, the thermal pulsation, and additional treatment that also will help the meibomian gland disease. These two entities are not are distinct from each other. Blepharitis, anterior blepharitis from posterior blepharitis, or now known as meibomian gland disease, but the correlation between the two is very high. And of course, you have to treat slightly differently, but there's great overlap between the two.
Dr. Dimitri, if you let me comment a word on the treatment.
Greater detail. Go ahead, Dr. Jarad.
Yes, I found out mainly in this all this modern treatment, I found out actually mechanical milking of the meibomian gland using 2 cotton tip that might many times solve the problem. Do it once and it solved the problem. And some patient, maybe they need to do it every now and then, but I found it as effective as like the LipoFlow, because we're doing LipoFlow as well, yes. But we're still relying that mechanical debridement whenever doable, if the patient cooperative using under the microscope 2 cotton tip, I think it would work well as well.
You are referring more to the meibomian gland disease, right?
Yes.
Rather than to the anterior blepharitis. Here, the scrubs would work, and I agree with you. You could use many of the modalities. Our company is developing a milking procedure for both anterior blepharitis and posterior blepharitis. And I agree with you. The principle is the same. You need something supporting in the back, and you don't need big, big devices. A small handheld device can do the trick, whether manually or with other more sophisticated systems. The results will be very good. Now, again, I want to give you the stage back, Dr. Jaradi, to talk about trachoma, which is also related. I mean, these are things that where the eyelid is related to the ocular surface, to the cornea, and may affect vision.
I think so in our area, one of the,
every single word on your slide.
Come again?
Go ahead, please.
Okay, I said one of the most important disease, I think, in our area, in the Gulf area mainly, is the trachoma that is caused by the intracellular parasites, the gram-negative bacterium chlamydia trachomatis. While in our area, it's very common, mainly in elderly, those who have entrapped the disease early in childhood. So that leads to cicatrization of the ocular surface and entropium, rubbing the cornea, ulcers, scars, severe dry eyes because of cicatricial reaction over the conjunctiva, obliteration of the lacrimal gland. And I think patients are suffering quite a lot from the physically and psychologically as well. Important to mention that early in the 80s, one study done by Professor Tabara has shown that trachoma is the second leading cause of blindness, of preventive blindness in our area. And as well, around 22% of the population have had intraepithelial trachoma, either in active form or in inactive scar form. Though they have done, mainly in Saudi Arabia and the Gulf area, quite an important work to eradicate the disease, but still in elderly, those have entrapped the disease at early childhood, still suffering from the disease. We can see it quite a lot still, mainly in Saudi Arabia. Well, the disease leads to mainly to entropium and to trichiasis. That's the direct impact in the cornea, apart from the what we call obliteration of the lacrimal gland and severe dry eyes. So whenever you are facing, here to mention the trachoma disease, mainly in active form, where we see the follicular reaction of the cornea, which is quite characteristic of the conjunctiva, sorry, to start the Zitromax, I think we used to give Zitromax for 3 days, 3 consecutive days, to be repeated after 10 days. So practically we are covering more than 2 weeks of active antibiotic again, which is quite effective against the trachoma. And when it comes to surgical treatment, here we have the first to address is, apart definitely doing the dry eyes management, but by all lubrication, all means, but still the mechanical factor, the trichiasis and entropium, that we have to go to surgical treatment, surgical management of the eyelid. We used to practice what we call the tarsal tarsotomy quite a lot when I used to be in Saudi Arabia as well. I have done on daily basis, we do this procedure, that we do a transverse tarsotomy. And by cutting the cicatricial reaction and the scar in the upper tarsal, and then putting two stitches to avert the upper eyelid. I think many doctors, mainly those who work in Saudi Arabia in the Gulf, they are quite familiar with this procedure as well. Again,
Jaradi here, I'd like to comment before we move on, that this is something that can't be overlooked. And as you said, the generational differences are evident. I remember in my trips to the region and other places also, you start finding that this disease is on the decline. You see it more often, as you said, in elderly people before going to have their cataract surgery. You will find inactive trachoma for practically everybody. And you look at the younger patients who are coming for other ophthalmic conditions, there's no evidence of trachoma. So this relates probably to the methods of hygiene that have become prevalent all over the world practically now. And that's why we're seeing less of it, except in the elderly patients. I was going to ask you if you can show just quickly, time permitting, how are we doing? We're doing well on time. So if you can just explain to the audience, please, the technique you are describing here.
Well, the technique first, I used to use a large speculum, the largest speculum for the Calasian speculum, just to hold the upper eyelid, invert it, and then I do the transverse cut of the upper tarsus. Then here we can, I think if you can see the arrow, we used to pass 2 Vicryl 6.0, and the upper edge of the lower part of the tarsus that's been cut, then passed behind the upper part of the tarsus and tied over the skin. That would invert the lid margin to the outside here, as in the edge figure here. Well, that's in brief. I mean, unfortunately, I didn't have video to show it in details. But as you have mentioned as well, I think I've noticed that mainly in the Gulf area, many doctors coming from countries that they probably never heard about trachoma. And I think they overlooking much the diagnosis of trachoma. And it's important to keep in mind before doing any other procedure, mainly cataract, to rehabilitate the ocular surface by addressing this issue of the ocular surface disease, because leading mainly in cornea transplant, whenever we have any scar, haze, and the origin is trachoma and entropium, secondary entropium, whatever we do for cornea transplant, my experience that it's recurrent ulcer and recurrent erosion of the cornea. So definitely we have to do this procedure just to revert the eyelid and remove the eyelashes. Sometimes if a few eyelashes, we can do epilation as well or cauterization, but it's a must do to treat the eyelid and the eyelashes problem before proceeding with the keratoplasty. That's what we used to do exactly. Giving time rehabilitation of ocular surface before doing the keratoplasty. Otherwise, it will do erosion again and corneal problem again in the graft.
Exactly. So rehabilitation of the ocular surface, if you ignore it and you run, and everybody in the audience, I think, knows that, but it's good to, you cannot overemphasize this because the patient is worried about their cornea, they're not seeing well, and you're telling them your lids are, the lashes are coming in the way. They will not appreciate that. I think these pictures you are showing is a modification of the Weiss or Weiss procedure that many of the established ophthalmologists in the region have learned to do a lot, and it's important to do that. There are other procedures that were developed that are a little bit more extensive, but that would be for the purpose of solving the eyelid. But for rehabilitating the surface, this would be good enough. Do you want to move on to the next topic? So
Yes. Well,
yeah. Vernal
another
and
conditions which very common in our area, they are the allergic condition, mainly the vernal keratoconjunctivitis, then the atopic keratoconjunctivitis. Before proceeding in details to these two conditions, I would like to mention the conditions of allergic disease of the ocular surface. So practically, they are the contact dermatoblepharitis, which condition of the skin and the skin of the eyelid mainly with rubbing, and it's practically anaphylactic reaction, the IgE related. The atopic dermatitis is mainly condition of the skin, and it affects as well the eyelid and the margin of the eyelid, and sometimes conjunctivitis. Hay fever, quite common, caused by the pollen mainly, and it's the IgE, the type 1 sensitivity. That's the little distinction from the vernal keratoconjunctivitis. I think the more relevant here, which is type 1 and type 4 hypersensitivity. That distinction, and it's more more persisting conditions. We can have it all over the years, associated with some sometimes dermatitis and some other conditions as well, like asthma. And it affects children and adults at the same time, and usually, as I mentioned, it's like more smoldering than the hay fever. The atopic conditions, which is the type 4, mainly type 4 cell-mediated hypersensitivity.
Before you go on, I just, maybe you're going to talk about it. You want to discuss briefly your choice of mast cell stabilizers or antihistamines?
Yes, I will come just because for the audience to be familiar with the different kind of the allergies. So we mentioned the contact dermatoblepharitis, dermatitis, hay fever, vernal keratoconjunctivitis, atopic keratoconjunctivitis, and the contact lens induced. For the vernal type, well, the most common cause is the pollen, and as we have mentioned, it's type 1 and type 4 hypersensitivity. And it's, well, it affects the conjunctiva, the tarsal conjunctiva, bulbar conjunctiva, limbus, and cornea. And as we may see here at the tarsal form, we have the giant papillae, limbal hypertrophy, gelatinous hypertrophy, and the trended dots as well. They are very characteristic of this disease. And well, that can lead as well to limbal cell destruction if it's non-treated well. As well at the level of the cornea, it may vary from punctate keratitis to this shield ulcer if it's untreated. While shield ulcer might be attributed to mechanical effect as well to the enzyme secreted during the allergic reaction, proteolytic enzyme, which can lead to this.
Can I ask you a question about shield ulcers? I'm sure many people in the audience hear the word ulcer and they immediately assume there is a collagen degradation and a problem of a melt in the cornea, whereas general histology shows deposition of fibrin and elevation. It is something on top of the cornea rather than a depression in the cornea. Of course, if you remove it, there will be a groove. What's your experience with that? Have you attempted to remove them mechanically, and how deep do they go in your experience in the cornea?
Well, my treatment is intensive steroid, preservative-free steroids, intensive lubrication, sometimes with contact lens, and most of them, they do very well. I never attempt to remove them. No, I trust just treat them.
I was going to go now and say, in my mind, the biggest problem with vernal keratoconjunctivitis is glaucoma. We have seen, unfortunately, over and over again, patients who are given steroids that help them. And then the doctor tells them, you don't need the steroids because they may cause glaucoma, etc. And then the patients don't trust the doctor. They trust the medicine, and they go to a pharmacy. As you know, in many countries, it's available. You don't need the doctor to renew the medications. And they start putting these magic drops that help them at the cost of elevated intraocular pressure. And when they come back to see the doctors, they come back with advanced glaucoma, unfortunately. I've seen many children going blind because of VKC. Very, very difficult problem. And it's something that I am sure is not rare in the Middle East either.
Well, I think the fluorometenolone, that works well in the disease. I combine always fluorometenolone 4 times a day with antihistamine drops. And I advise patients take the fluorometenolone for 10 days to 14 days whenever needed, and to keep the antihistamine for long time. I think it's a combination working well. And fluorometenolone, I haven't seen much complication. I'm using this as well, as I will mention later, in keratoconus subgroup, pediatric keratoconus and allergy, because I think we are attributing allergy to development of keratoconus. I keep my patient the fluorometenolone for long period to be self-initiated whenever needed, with a period not more than 2 weeks, 10 days to 2 weeks. Really, I don't know with the fluorometenolone if I experienced any serious problem.
The problem, I think, is that it's very difficult to tell because the patient doesn't come back necessarily if they're having problem. And so one has to be careful about prolonged steroid use. And I like your approach of combining 2 medications so that the patient, and you tell them you put these 2 together and you stop one because it's more dangerous, and keep antihistamines. Otherwise, if they get the taste of steroids only, and nothing else is going to be as good as steroids in this condition to them, and then they may start doubting the doctor. Anyhow, we need to go on, but thank you again for all
to mention, like, if seeing such a cornea, the one I'm showing now, I prefer to start steroid, taking the risk, but not keeping the cornea in this way. Anyway, in the atopic keratoconjunctivitis, it's a type 4 hypersensitivity. That's why always nothing works till the antihistamine, to mention about the treatment. In this condition, antihistamine doesn't work much because it's type 4 hypersensitivity, mostly associated with eczematous conditions of the skin around the eye or somewhere else in the body, leads to cicatricial ectropin trichosis and many other problems with the ocular surface if not treated well. And it's very smoldering, very fulminant disease, actually. I've seen so many patients, bad experience, not good experience, with many patients. You have to keep them on steroid, and that's for cataract formation is very common, and the glaucoma as well. But again, we have to decide. And seeing this patient as well, with those patients using medication for a long time, they are having precipitated this condition as well, which is confused many times between the medicamentosa and acute keratoconjunctivitis. However, so we have to start the treatment again. In this condition, I think we have no choice but steroid. Again, mild steroid may help. Instructing the patient and telling the patient no test to know what causing allergy in any kind of eye allergy, because they ask what is causing my allergy. I tell them, okay, there's only one test, is good observation. You have to have good observation, you have to know what is causing your allergy and try to avoid it. I'm not aware of, I don't know, Dr. Dimitri, if you have any test for the eye to know a specific allergic condition or just observation.
In these patients, at the end, it's a clinical observation. You're looking at the patient, and if you're looking in the dark room and all you're seeing is a cornea or an eyelid, you're going to miss many patients with this condition. As you said earlier, eczema, thickened skin, dryness is very common in these patients. So you look at the patient, you know their age, and you look at the skin around their lids, and that part of the face may look 10 years or 20 years older than the rest of the face, with wrinkles and erythema and so on. And that would be the time where you say, oops, this is the condition that I had overlooked, and then you say there's eczema, and then it becomes atopic keratoconjunctivitis as a potential diagnosis. Many of these patients can also be confused with ocular cicatricial pemphigoid, much more serious condition. And there you have to lower the lid down and look and see if there's subconjunctival scarring, which is not present in this condition. This is always a common differential diagnosis between the two.
Here, as we said, when we advise for the treatment, just avoid the allergic substance, the allergen, whatever it is, by washing hands, keeping away from any pollen or whatever. That applies to all conditions, allergic conditions of the eye. Steroid, antihistamine, combining both. Oral steroid here mentioned, but I never give the subtenon or sometimes in the tarsal or lower lid steroid in very severe case. I give dexamethasone sometimes like 2 milligram or maximum 4 milligram because it's short acting, doesn't stay. As well, cyclosporine that would help maintaining the immunity at low level as well, that controlling immunity as well. I keep patients with severe conditions with not the atopia, the other conditions like hay fever and the keratoconjunctivitis. I give them cyclosporine. It works well as well in those conditions.
Yeah, and we're not talking about 0.05% here, 1 or 2% cyclosporin.
Exactly.
Has to be prepared by a pharmacy in a sterile condition. And always, if you know the pharmacy that's doing it and they do a good job, then it's fine. These are sometimes unregulated, and you may end up having I mean, there have been many incidents of outbreaks of infection coming from these pharmacies. So keep an eye and make sure it's a pharmacy you trust. Okay, we are running out of time, so we have to go faster.
Okay, moving to the topic that related to allergy, which is the keratoconus, mainly the keratoconus in pediatric age group. So years ago, we never believed that it existing in young age, like 7 and 8 years. We have seen patients very young with keratoconus, with hydrops and stage 4 keratoconus. We have made survey at our hospital in Beirut over 5 years. We found out that around 0.5% among the pediatric patients who visited the hospital, they have had keratoconus, versus 3% in adult patients. That's very like significant number. And most of them, they are stage 4 or quite a number, significant. 2 of them, they presented with hydrops. It means at age of 9 or 10 years, they have very advanced keratoconus that testify probably that keratoconus started earlier. Well, the good question, is it family history or allergy? Because as we know new theory that it's only allergy causing keratoconus. Not all of them, probably 50 to 60% have a history of allergy, but not all of them. As well, few number of them having a history of keratoconus. So still keratoconus in pediatric age group, not that much correlated to allergy. It's correlated, but not very high, and not to family history, still a sporadic disease as well.
Question for you. I'm sure this wasn't done at that time. Did you survey rubbing? Because as you know, our friend Damien got
yes. I'm referring to this.
And allergic disease causes rubbing, and rubbing causes keratoconus, especially in young, very mechanically prone corneas for ectasia.
Yeah, that's what we're referring. And actually, we do believe, personally, that's why I give the fluoromethanol for most of the keratoconus patients is rubbing. And I think proteolytic enzyme from the allergic reaction can cause degradation. But that's what we have said, not all of them, and significant number, 40 to 50% having no allergy at all. So we cannot say allergy equal rubbing equal keratoconus or keratoconus equal rubbing. No, definitely we haven't family history.
I agree with you, even though I don't agree that rubbing can only come if you have allergies. Some people rub without allergy, but of course you have allergy, you rub more. There's a good strong correlation, but not necessarily causation.
Here I'm just showing case just with the allergy. So I have a patient with severe allergic conjunctivitis with gallstone and having this picture. He presented to me, he was around 10 years old when I saw him first. I'm following up with him more than 8 years. He was referred to me to do cross-linking, which I thought this is the allergy causing this and I should address the allergy. He did very well. I was able till now to manage allergy, control allergy, and he's stable. He never progressed. In such conditions, I think, yes, allergy rubbing is the cause of this distortion, but not in all cases. And anyway, we came up with, we tried to put an algorithm, guidelines, how to approach pediatric keratoconus, how to treat. We were the first to publish as well in the indication of ring in pediatric. Is it indicated? Is it feasible? Yes, under local anesthesia as well, using the femtosecond. Again, indication for ring in pediatric is either to treat drop of corrected distance visual acuity, because this is the only way to do it, and avoiding keratoplasty. And or we have a severe anisometropia. Sometimes the anisometropia we can address by putting ring in the high myopic eye, and it works very well as well. Some patients have put ICL to address anisometropia as well. Cross-linking is mandatory in pediatric age group. We have a recurrence over 5 years, around 5 to 6%. We have recurrence rate of keratoconus, even with cross-linking, that we repeated cross-linking as well. So again, doing ring sometime in very specific case, the phakic IOL in very specific case, cross-linking mandatory, and we keep monitoring over the years because it might be recurrent. When do suspect this keratoconus in pediatric age group? So we thought that any allergic condition and eye rubbing, the patient should be investigated for keratoconus. That's how we are practicing. Family history as well. We do screen all the family members. As soon as they can rest their chin on the topolizer, we do the topography, age of 8 or 9 or so. Any high astigmatism with drop of corrected distance visual acuity as well, we have to suspect keratoconus. That's what I want to say. So keratoconus in pediatric age group is most of the time much overlooked and not paying much attention to this diagnosis, and something we have to keep in mind, because we think that early diagnosis and treatment with cross-linking that may stop the disease and solve a major problem in the future. I have
for a great discussion here. We only have 2 more minutes for another 20 slides. Okay. So let's move on now. Thank you again. I mean, this was really excellent, and I'm sure going to have cause a lot of questions. Here we were going to have a good discussion about contact lens related keratitis. As the audience knows, as you see on the slide on the right, there are infectious and non-infectious. Never forget the infections, but the non-infectious include pannus, corneal edema, allergy, and even aggravation of the allergic conditions that Dr. Jaradi was talking about before, including patients with keratoconus, with rubbing, etc., etc. Time will not allow us, if you go to the next slide, to go to the infectious. Just one good example here to a table that you always have to think about: bacterial, acanthamoeba, and fungal. I'm sure the audience knows about that. I was planning to go over these one by one, but at the end of the day, for anybody who's wearing contact lens and they get one tiny little scratch or a white dot infiltrate, we've had cases where one day the contact lens is there. The first thing to do, remove the contact lens, no patching. I know many people used to patch, but if you patch, and I've seen it several times in the emergency room, the residents come back the following, you see the whole cornea is white, even though there was no infiltrate. Contact lens related keratitis, think of infection. You're always going to manage all the other non-infectious keratitis entities. So these are very serious. The outcome depends on proper diagnosis and appropriate treatment, whether it's bacterial, acanthamoeba, and fungus. I'm going to move to the next slide, please. And sorry, we have to go quickly here again to the conditions, other conditions, which is corneal dystrophies, degeneration, opacities, and neovascularization. You know, even when Elias was in Boston working together, my lab was focusing on all these entities. You can see that you can go not only epithelial and subepithelial dystrophies that you're all familiar with. There are others that are stromal dystrophies that we see a lot of, especially in the Middle East, sometimes in areas where there's high consanguinity, and then endothelial dystrophies. But regarding this particular case here, we're going to be focusing on the superficial. Just a reminder, map.fingerprint dystrophy. Next slide, please. And just to go quickly here, you're going to see some subepithelial changes, epithelial basement membrane dystrophy, and Meesman's dystrophy. Meesman's dystrophy, you can see the opacities in the epithelial layer. They look like cells. They are not at the basement membrane. High magnification slit lamp microscopy will tell you the difference. I've seen reports of people going ahead and treating this and doing lamellar, etc., etc. And how do we know? We saw histology, cross sections of corneas in papers. None of that is necessary. The patients are seeing well in general, and it's a nice thing to remember, and you leave it alone. You tell the patient this, you have to tell the patient what it is and avoid having to operate on something benign just because it's interesting. And then maybe we'll go to the example of mapped out fingerprint dystrophy here. As you know here, the problem is the basement membrane, and the treatment is very simple. It is to remove this basement membrane irregularities in the younger patients. I mean, this is an overgeneralization, but years of experience tells me the young patients, they come with severe pain. You take care of their pain, you remove it, you patch it, you put a contact lens, you do anterior stromal puncture or basement membrane anchorage procedure, whichever term you want to use. And they have recurrent erosions. At night, their lids dry on the surface, and when they open their lid, it breaks and they have severe pain. That's one type. The type that everybody misses, it is after cataract surgery. You come, you operate, or after sometimes LASIK, and you find out that this patient's vision is not exactly what it should be. Everything else is fine. And you look carefully, you start seeing basement membrane dystrophy, but no pain. And that's why, because in our mind, there is a strong association between pain, severe pain, wakes you up at night, and basement membrane dystrophy. We may miss in the older patients the asymptomatic but visually significant basement membrane dystrophy. The pathogenesis are similar. You break it, it heals. It takes several weeks for the basement membrane to heal, but then the vision would be affected, and that's something we cannot forget about.
Yeah, we used to call that silent dystrophy.
Silent dystrophy, good point. Now we move from the dystrophies to the opacities and neovascularization. This list that you are seeing in front of you, again, I'm gonna go back, please. One is a very long list, and it includes, keratoconus, which you heard Dr. Jaradi spoke about, a variant, pellucid marginal degeneration, peripheral corneal degenerations, conjunctival degenerations. These are topics that are straightforward. People may or may not be familiar with them. And this is a fraction of the total list. I've spent 30 years focusing on corneal neovascularization, understanding the pathogenesis. Fortunately, we pulled out these slides in the interest of time, but these, many of them affect the ocular surface, which are listed here. I'm going to give you just two examples of the amyloid and of a lipid degeneration. And then at that point, we will break and go through questions. This amyloid here, you can see the birefringence even showing on the slide to the right, and then an opacity. And Dr. Saleh, we will go to you now. This is a lipid degeneration. That next slide, please. That I'm sure many of you are familiar with. And then you could do a rotating corneal graft or something like that to take care of it, or a total corneal transplant and take care of the condition. Our next section is gonna be management of ocular surface disease, but before that, we take a break, meaning break Q&A session. And Dr. Saleh, we're gonna go on mute, or we stay on the microphone, but we'll have you please ask the questions. You've been collecting questions from the audience, I believe.
Yeah, I'm receiving a few questions.
We're 5 minutes over time, not as much as I was afraid of, so we're okay.
So I'll keep it for you guys to decide. Since we are a little bit late, it's like 5 minutes further. We can, and the question will be more into the discussion of the management. We can stop now, give 5 minutes, but I'm worried that we will be late, or we carry on for 30 minutes and we stop 10 minutes for discussion, so we can finish on time at 11. What do you think? It's your decision.
Yeah, okay. Let's move on. I hope.
But then we have 30 minutes, please, Dr. Dimitri and Dr. Elias. So
Okay.
it will be 10:15 our time here, so it's almost like 1 hour before midnight, and we'll keep 10 minutes for the questions, okay?
Fantastic. We
Beautiful.
have
So you
Dr.
control
Gerardi.
the time now. I'll be on mute, and you got 30 minutes. Beautiful.
Thank you. Dr.
Just
Gerardi has a lot
remind
of cases.
the delegates, whoever have a question, you can send it as well. Not only to my mobile, you can send it through the chat box, so I can collect the question. Thank you.
So we're going to now focus on the ocular surface reconstruction. We're going into a more surgical approach here and more videos, hopefully. And I will comment. You can see we are friendly with each other, no major contradictions, and that will continue going on.
Okay, do you see the screen?
Go ahead, yes.
Okay, so I would like to present a few cases. I have many, but just a few cases which I found them not very usual. This is a dermoid cyst of the ocular surface in pediatric group. He was like around 5 years with severe drop affecting the visual axis. So going to remove it, then doing corneal transplant rejection. So I decided to do combined procedures. That's removing the dermoid cyst and then trying to do the bulk at the same time. And as well, I call this technique a little bit the split and patch technique, because I use the patient own corneal tissue. I split it, upper and lower part, to patch the upper part of the cornea and the sclera as well, which became very, very thin, as you may see in this video.
I'm going to be commenting with you, if you don't mind, as you're showing the video. The audience has to note here that these dermoid cysts, sometimes if you don't do an ultrasound, you may think they are superficial, but they are usually deeper than we think. And because they're in the periphery, I commend you, Dr. Gerardi, here for not removing it completely, but leaving a little haze down below is not the end of the world.
And I went very deep in the sclera, up to the choroid, as you may see.
Yes.
And it worked. Luckily, I didn't penetrate, and I was able to remove it all. And here coming a little bit modifying when I did the trephinization of the cornea, doing the bulk, because one part of the cornea is very thin, the upper part, the lower part still very thick. That's why I used manual trephinization partially, that I'm pressing in the lower part rather than the upper part, not to penetrate the cornea, because the upper part of the cornea become very, very thin. Then I was able to do the...
While you're showing the video, but I'm questioning the wisdom. I know the patient did well, but my advice to people that not go in the visual axis if you can help it in these young children. It can always be done later in life, as long as they don't have severe astigmatism.
Well, but they have deep...
That part of the cornea you are removing now is still healthy. I'm not criticizing you. I'm just having conversation here.
Yeah, but let
the video keep going. Yeah.
Yeah, the dermoid reached the visual axis. That was the problem. I have to go and remove it. I cannot keep it because the patient worsens with time.
That's where I disagree. I mean, reaching visual axis and blocking the visual axis are two different things. But your surgical technique is so good. I mean, if everybody is a talented surgeon like you, maybe they should be doing this.
Yeah, I did. And here I will show other part, how to manage the upper part, which has become very thin. Here I came the split and patch. This is the lower part of the cornea, which was still healthy. I split it into two parts, and I patched the upper part of the sclera and the limbus. I set it in place just to give enough corneal thickness, and hopefully it will conjunctivize with becoming conjunctival. I'm here showing many months or weeks before surgery. It works very, very well. Well, it's not an easy, but it's very rare conditions that I really like to show, and it was quite challenging as well. Here showing other case.
Here, before you go on, keep this slide. Number one is that if the visual axis is involved, the biggest problem is astigmatism. Of course, you came up with a great result. But it's good to think that maybe the astigmatism after the surgery, after this whole elegant technique, may end up being worse than what you started with. So that has to be kept in mind and told to the patient and to the parents in this case. Second is that there could be complications by going too deep. And clearly here it's affecting the visual axis. And by doing your lamellar, you clear the axis. But for cases that are not as involved as this, I hope you agree, Dr. Gerardi, that maybe a more conservative approach of making it flatter, it remains a little bit hazy, cut down the astigmatism, and then determine the astigmatism, make the decision later on in a two-stage procedure rather than at the same time.
I do agree 100%.
To allow us to allow you to do this, and congratulations on a great outcome. Next.
Well, the second case for the ocular surface, things I will discuss later, ocular graft versus host. That's a, as you may see, the cornea melting, vascularized, and it was sutured in many places because it went melting many times and affecting both eyes. Here I decide to go, I will show the video that I go one procedure because it's an it's graft versus host. You can see in the upper part, I took the donor, the one who gave the bone marrow for the patient. I took the limbal cells. He was the brother of the patient. Actually, he was very generous to agree to give limbal cell and conjunctival stem cell from the lower fornix. Then I dissected the whole ocular surface with the amniotic membrane. I transplanted as well the donor, the one who donated the bone marrow. I took from him the limbal cell, and I took from him the conjunctival stem cell as well. And I transplanted in the patient eye. I'm showing the technique harvesting the limbus and harvesting as well what we believe the conjunctival stem cell, which they are in part residing in the lower fornix. So here I put amniotic membrane as well for the patient. Here coming to the
let me comment about this again. This is very interesting. We've done this. I think we were the first to do this procedure, but without the conjunctival. We looked at the outcome and we realized that the scleral lens was better, so we stopped doing this. I have to admit, we only did the limbal transplantation because I was afraid to take too much tissue from the donor. By the way, this is applicable for patients where you know that there is a living related donor that caused it. And I will say, before people do the surgery, I mean, this is a very, very advanced case. No criticism here, just a little note on the side. Use of a scleral contact lens is like a miracle for these patients. The first patient who ever used the scleral contact lens for this condition was one of my patients. I did not recommend it. He went to a doctor who had, who was putting who invented the contact lens in Boston. I think you were there, a fellow with me, Elias, at that time.
Yeah.
And that patient sent me a note saying, Dr. Azar, I know you didn't recommend this, but I put this in my eye, and he was going to be coming for the surgery, and now my condition has been cured. I'm not criticizing you, but I want you to know about this. And then so from that, I contacted Dr. Rosenbaum, who was the one who started the contact lens situation, scleral contact lenses. And we started treating together many of the patients with ocular graft versus host disease.
Yeah, I do agree, but that would work in early case, not such case, the cornea perforated scar, pan.
I'm not criticizing you. I'm saying just for the audience not to rush and start.
Of course. And here showing superficial keratectomy and then transplanting the limbal cell and conjunctival cell anteriorly here, the one I harvested from the patient. Well, and then putting amniotic membrane. After doing this keratectomy, I put amniotic membrane at the surface to help establishing new epithelium and healthy epithelium. That procedure worked very, very well. I will show you a later slide how the patient had become.
Here I disagree with you fully, but this is for the audience to listen to. What helped this patient was the fact you put new epithelium. It didn't have to come from the living related donor, because as I said, when we did the studies using living related donor, to avoid the graft rejection, so to speak, it really had no impact relative to just a simple managing the ocular surface. So,
but don't you think that would be related to the
audience to believe that it is necessary to go find the living related donor? I hope you agree.
In some cases, that depends on the allogenicity of the immune system. So how much the immune system has converted to the donor immune system, completely or partially.
All I'm saying is that it's not that simple. Anyhow, let's move on. Differences of opinion are always good.
Well, again, complicated pterygium, recurrent complicated pterygium, we do think that it's a severe fibrovascular ingrowth. Doing the first excision didn't work, recurrent. They sent to me. This patient with combined cataract as well. Well, it's advised mostly to do the pterygium first, then doing the cataract. Sometimes the patient doesn't like to have two surgery at the same time. So you're still hearing me, right? Hello?
Yes, yes, we hear you, Elias.
Yeah,
Carry on.
okay. And then I decided to do
for a moment. Go ahead.
Conjunctival and limbal cell transplant at the same time. Here showing that I took part of the limbus from the upper part at 12 o'clock and did conjunctiva. I think this is the most that works with me in such conditions, that I took conjunctiva and limbus, either from the same eye or from the other eye, that depends. We don't have the glue here, so have to do manual suturing. Definitely, if we have the glue, that will spare enough time as well.
Yeah, this is a question I was going to ask, if you use the fibrin glue, because Dr. Sadir Hanush, he also comes originally from Lebanon, studied undergrad at the American University. He popularized the use of the fibrin glue.
Yeah. If it's available, I would use. In such case, it wasn't available. Here I proceeded to the cataract procedure, and I think I will mention something about the cataract procedure in this combined. Because of the corneal irregularity, in such case, I was able to see well, but sometimes if we're doing some combined with superficial keratectomy and cataract, that obscure the vision quite a lot, distortion of vision. It may hinder the phaco. And these conditions, I will show end of the video what we can do. In other case, not the same case. Other case, I did Salzmann nodule excision, superficial keratectomy at the center and paracentral area of the cornea. And I proceeded the same time for cataract procedure. Definitely, the vision was much distorted, not able. So the idea here that we can do, and this is the Salzmann nodule case when I did the superficial keratectomy, not able to see well. We took a hard contact lens. The hard contact lens, I did some manual reshaping at the incision site. So putting hard contact lens, and we published this as well in keratoconus, advanced keratoconus, combined cataract and advanced keratoconus. That would help. As seen in this case, after putting the contact lens, visibility it become very, very adequate to perform cataract surgery. Here, customized lens, as you may see here, that we made notch in the contact lens at the level of my incision. Well, that's to present about it in this case.
Okay, one question to you here before. Let's skip the ocular surface medicamentosa and focus on the procedures, I hope, because we have many topics to discuss. We'll also skip and go only on the videos. I think the audience would like that. Say, supposing you want to do these two procedures separate from each other at two different times, how do you recommend to the audience when to do cataract first and pterygium later, or pterygium first and cataract later?
Definitely, I would go for the
idea of the hard contact lens. Brilliant as always, but it's simple recommendations for people who want to be a little more conservative, let's say.
I would recommend definitely going pterygium first, doing pterygium, doing the ocular surface looking good, having good visibility, and then proceeding with at least for the optical purpose. So we may change the astigmatism, we may change the power of the cornea. So definitely going for the pterygium excision and rehabilitation of the ocular surface.
I agree 100%. Let's move on, Dr. Jaradi. I mean, these are amazing cases. The people are getting, the audience, a treat here. Let's skip the medicamentosa. They're all, there's
the medicamentosa.
And skip the corneal melts so that we can go to the audience, as we promised Dr. Saleh. As you all know, well, one point here, that there are many, many serious conditions, especially the immunoregulatory things that can cause limbal stem cell deficiency. You have to think about infections, bacteria, viral, amoeba, as we mentioned earlier, plus the limbal stem cell deficiency, inflammatory conditions, Wegener granulomatosis, ocular cicatricial pemphigoid, etc. All these
and we have
conditions,
to add here blast injury in our area, which is quite common, huh?
which is
Blast injuries.
oh, and blast injuries. Yeah, and so here we're talking about melts in the cornea. They can come from inflammation, from all the conditions we mentioned, as well as limbal stem cell deficiency, which is, you know, this is an extreme case of dry eye, so I think it's appropriate to focus on that. You have videos
in this
here?
case, if you give me a couple of minutes, just to present this case of a patient that received blast injury around 30 years ago in the left eye with multiple repair. He ended up only hand movement to light perception in the left eye, completely almost white, opaque cornea, the limbal cells not looking healthy at all. He's living happily with one eye till the point in the right eye he's seeing very, very clearly. Well, till the point he gets central retinal artery occlusion in the good eye.
Okay.
Here we can see the left eye after the blast injuries and the multiple repair. He's been like this for more than 30 years with light perception to hand movement near face. This is the right eye, which was looking very, very good till the point he lost the vision immediately because of the central retinal artery occlusion. He's showing the fluorescence. At this moment, where he came to me, I decided to do the co-management of limbal cell transplant, autograft, and cornea from the other eye. Here, the right eye, which is no light perception with central retinal artery occlusion, I harvested the limbus. I harvested good limbus because non-seeing eye with the cornea. Then I switched to the other eye. I did similar technique.
Let me comment a little bit again for the audience who are not familiar with this. This is the patients would not let you ever touch their good eye if they got a blast in the other eye, except in this rare condition where I had a similar case when they had a malignancy and they needed to have proton beam treatment for that eye and ended up losing vision completely. And then the eye, like this case that you are showing, then you can, there's nothing better than getting limbal stem cells from the other eye. But if I would tell you, if it works with all this limbus, it could also work with small limbal cells, so you don't need to take as much. This could have been done 30 years earlier or maybe 20 years earlier. But please keep showing us a little comment on the side.
Exactly. You know, when I started the procedure, I was planning to do 360. Then I stopped. I said, why 360? I took on less than 1/3, around 1/4, and it did very, very well.
You divide it into components and put it around. Exactly. But now the patient agreed. In the past, they won't let you touch the other eye.
Definitely.
Because they're afraid you would blind them. But when the other eye is gone, it's gone. Yeah.
Here I am transplanting the donor from the other eye corner. Then I took the stem cells, which they look like around more than a little bit 1/4, like little bit 1/4. I put the limbus in place.
Oh, you put them all in one place. You did not cut usually what.
Yes. To me, the superior part. That's why I decided not to take, because the superior part it looks okay to me.
I see. So
that's why I didn't do it, and I kept the superior part without limbus because I thought it's good enough. And here showing weeks and months.
Oh, what a great result! Congratulations.
Definitely.
Just comment about the sutures here. And many people, as you know, use running sutures for expediency and to minimize astigmatism. It's always the best approach. But in cases like this, when you're going to have inflammation, sutures loosening, if you have one running or two running sutures, they will clearly come out and it'll be a big problem. So having interrupted sutures takes a little bit longer time, but this would allow the surgeon to remove the sutures. If you go back, just show us the picture from before with the interrupted sutures before you remove them. Oh, no, that's okay. Don't repeat the whole video.
Here, I think it's
here. Close to the end. Yes. So
suturing, I think it's very difficult. It's not easy. I think you want to see this one, right?
Yeah, you see here the interrupted sutures, and that's very good. Okay.
Yeah, and suturing this limbus.
Yeah.
Suturing the limbus and keeping a adequate suture tension, not to induce much astigmatism. I think it was very challenging. You put a stitch in the limbus, then it distorts the cornea, then you repeat, then you put transfixating suture from the cornea to the sclera, etc. Yeah, you have to manipulate a little bit the technique.
So I have one additional comment about this. Patients who have injury in one eye only and the other eye is fine, I think the eye could be rehabilitated easily and give them hope, and they're not running with one eye only by taking small part of the limbus from the unaffected eye. It requires trust in the doctor, clear explanation, sharing articles about that. Schaefer Sang and Ken Kenyon have written a lot about this, and after that there have been many procedures. You get tiny little piece, cut it into small components and scatter it around the periphery, and it would allow the surface to reheal. And then at some point they would, when it's completely reepithelialized, having a corneal graft could be an option that would be discussed with these patients.
I want to mention this.
Here you had to do it because this patient ended up having an unfortunate condition in the other eye.
What do you think about the procedure? I have seen it with many surgeons presenting it, cutting the limbus into small pieces, and they embedded into the stroma, in many places into the stroma, not in the periphery. Have you seen this, or have you done this?
I've seen. I think in the stroma, now there are people who are thinking about stromal stem cells also, but for a case like this, I mean, you do it exactly like you did, but maybe not a big arc. You cut that and you put it in 4 places, and you put four little sutures at the edge. You have to remove. Important thing here is to remove, like you did very ably, to remove the existing surface epithelium, all the neovascularization, the pannus, with minimal cautery. That's critical. Because if you cauterize more, you're adding to the underlying condition.
Very true.
And I like but in patients, say this particular patient now, God forbid, has serious problems, and the cornea is either rejecting, or the limbal deficiency remains very big, or people who have bilateral grafts, then the keratoprosthesis, and we've placed a lot of these in the early days in Boston and then later in Illinois. Our 2 combined programs account for more than probably half the keratoprosthesis in the whole world between Illinois and Boston. And these patients require a lot of management. It's not like you did the surgery and you say bye-bye to the patient. They become your friends. You have to be available for them day and night. And we owe a lot to Professor Dolman, who was my mentor in Boston, and later my colleague, who has brought this keratoprosthesis to really help take care of the serious, very serious bilateral conditions.
I do agree. That's why I'm trying to avoid prosthesis, because I don't want patients to stay with me.
No, that's realistic. There's nothing wrong in it. But if the worst is to say, yeah, I'd like to do it, and then you abandon the patient because there will be melts around it. These are, especially if used for the difficult conditions that we are discussing here. By the way, for the audience, the future lectures will be about dry eye, simple dry eye, nothing as serious as the ones we are discussing here. Go ahead, one more video. Maybe we have time for one more video and then
the graft versus host disease, we've been discussing it earlier, and with the technique I have been showing that we harvested the limbal cells and conjunctival stem cells from the donor of the bone marrow, and then we put it in the donor. Here the video I have shown. I just want to show you that how it ended up my cornea. Look how it was before in the upper left part, and this is weeks to 2 months after. Everything became very quiet in the cornea, and it did very well. The patient vision was rehabilitated in a good way. I don't know why it worked.
This case you and I will keep disagreeing about, because I'm a believer in scleral lenses. And then there are many now medical approaches, neutrophil inhibitors. They are not approved yet, but the future is going to be good for these patients. And now again, this is much more severe than the average patient with ocular graft versus host disease. So what you are treating is the consequences of the disease rather than the disease itself, I think. And I'm agreeing with your management, but reinterpreting it slightly differently, if that's okay with you.
Well, a question in mind, Dr. Dimitri. I have a patient now been sent to me for management. He has punctate, early punctate epitheliopathy from graft versus host. And his treating physician, he's suggesting to me to put autologous serum. Why?
Yeah.
In mind, I was telling, well, we have to take the donor, take his blood from the donor.
Well,
Autologous
because
serum would aggravate the
no,
condition?
these ideas are all good, but at the end of the day, the problem is not that the donor, it is not the conjunctival epithelium that is being rejected here. The graft versus host disease is systemic disease, and the immunology has been very well characterized, and the conjunctiva and limbus play a very, very small role, unfortunately, in it. Had it been primarily a conjunctival limbal stem cell deficiency condition, maybe in this case it was, but in most patients, it's a systemic disease, no different than other systemic diseases, and therefore the treatment has to be, of course, primarily systemic, but the ocular injury is because of affection on the lacrimal gland, on the upper tarsus, on the lower tarsus, on immune factors, and paradoxically, by putting that scleral lens, and whether they put you didn't initially, we added the serum to it, etc. It's very, very good. But other things to be treated, including going in and pulling these fibers. I mean, I know used to have Wednesday morning for me our ocular graft versus disease, graft versus host disease coming, and we pull out the mucinous fibers out their things. Then we give them their serum, and they feel okay for a short time. But I'm saying when the contact lens, the scleral lens, it's called the PROS lens now, but there are many others on the market. I have no financial interest in this one. It really transforms the lives of these patients, at least in the short term that I've seen. And so this is one other way of treating these patients. And it has become
the scleral lens would work.
But now, why does it work? It's because it turns out the mechanical component maybe of just the lid falling on the surface in this very fragile environment seems to be enough to make the conditions so much better. And the pain and the misery of these patients from the movement on the lid on the surface and irritation of their nerves is abolished. But it takes several fits for that to work. These are not easy lenses to fit. A simple contact lens doesn't work. A regular hard contact lens doesn't work. It needs to be scleral. And now there are many scleral lens companies that are working on this indication. And many companies also are working, I know for sure, on dry eye treatments where they use ocular graft versus host disease as their primary target population because the disease is serious. They can get approval quickly. You don't need the number of patients who suffer from this, at least in the US, is less than 20,000 patients per year. And therefore, the regulatory approval is a bit easier. Anyhow, you have other cases, or shall we go now to Dr. Saleh for questions?
I think let's go for questions.
Okay, great. Dr. Saleh, the stage is yours.
Okay, thanks a lot. Actually, I really enjoyed the discussion. I really enjoyed as well, as much as my colleagues, we enjoyed the content and this kind of cases that you taught us both how to approach them. Now I'm gonna start with the questions. And I'm gonna put the question and you guys feel free, whoever wanna be commenting. The first one was, when you are doing a case of, let's say, pterygium, where you decided you take the pterygium first, and then you will approach to do the cataract surgery later on. How long time you keep between both cases, the pterygium followed by the phaco?
Dr. Jarrah, you go first.
Well, I would wait enough time first to have corneal clarities, and second to have diopter stability of the cornea. That's a must do it.
So what is enough time?
Well, not before month, 4 or 5 months at least. Well, you can do it sometime, you can say 2 months, but I don't think 2 months would be enough for the corneal remodeling as well and the corneal shape. Well, yeah, that's how I do believe.
May I add something, a friendly amendment here is that there is, it will all depend on the extent of the pterygium and how far it's going into the cornea, the degree of astigmatism that's present, because if you find out that, and depending on the procedure you're using, how much is your amniotic membrane, if you're using amniotic membrane or conjunctival transplant, encroaching on the cornea or not. And you want to allow time for the treatment to be tapered so that, and see whether there is a recurrence of the pterygium. So I think you tell the patient it's going to be 2 stages, 5 months or 3 months, or dependent on the surgery. And then you need to take topography measurements for sure. That's a very important point. You agree, Dr. Jaradi?
Yes, definitely. That's what I'm referring in the management for corneal stability. Exactly.
Good. Other questions?
Yes. Now, in that case, Dr. Jarada, that you did the Salzman nodule removal with the phaco, which K readings you have used?
Well, exactly. So in those cases, I refer to the other eye. I take the other eye, or I manage the average K reading, definitely, because there's no K reading. And mainly it's the Salzman in the center obscuring the, as I mentioned, obscuring the vision. So no point to take a K reading, but the average K reading.
Okay, thanks.
Can I add here one thing here? Because of the corneal irregularities, our friend is the hard contact lens. And I'm sure Dr. Jaradi agrees, and he didn't mention that. So before any of these surgical procedures, it's important to ask the question, is the reduction of vision due to the opacity or to the surface irregularity? So if you put a hard contact lens and you tell the patient this is only a test, because if you tell them we're giving you a hard lens, they will run away. You put the hard lens and you see what their vision is. If you find out their vision with the hard lens is 20/20, even with on top of the Salzman nodule, you cannot send them with a hard lens. Then you go in and shave the nodule and don't go deep, because it's not the opacity. You don't do lamellar surgery, you just try to make the surface smooth. And that can be done either with a blade or with an excimer laser, whatever your approach is. And that's a total 2-hour lecture of how you approach it. If you find out, even with a contact lens and over refraction, the patient's vision is bad, it means and usually these opacities, as we all know, are in the center of the cornea. The opacity itself is causing the reduction of vision. Then that will be a clear indication to remove it, go deeper, and put a lamellar transplant to it.
Well, thank you. Sorry, go ahead, Dr. Jarada.
Yeah, I do agree on that. I do the same in many conditions, mainly like sometimes I see coexisting conditions of corneal distortion, like advanced keratoconus and some retinal suspect problem. While the way to differentiate for me is this corneal or macular, I do this method as well. I fit hard contact lens just to differentiate the problem and to focus where the problem is. It hard contact lens, the cornea or the macula, and I think the same apply exactly.
And thank you for saying that, Dr. Jaradi. My advice to the audience is to make sure in their clinics, in your notes, whether it's electronic or not, if you have the ability to add things that are special to you, if you are seeing anterior segment disease cases, to put a place where you have to put an X, yes or no, hard contact lens over refraction needed, yes or no. Because if you are in the middle of thinking about what to do, you may forget to do that. But if you see it in front of you on the chart, you say, oh, I haven't done that. This would be good to do. And then it works very well. I had a great contact lens fitter colleague who was a professor, optometrist in Illinois, and I would send him my cases before surgery to do this. And I found out half the patients come back and tell me, sorry, I don't want the surgery, because the lens is working very well for me. He used to fit perfect lenses on patients where I thought they would need surgery. So always, if there is a non-surgical approach, it's always better. I mean, we don't have to tell this to anybody.
Again, something I use in the clinic as a substitute to hard contact lens, which I favor the hard contact, is doing the pinhole acuity as well. Pinhole, sometimes it gives a quick response, whether this is optical from the cornea or somewhere else. So if this is the scar a problem, the scar, not irregularity, if the scar, definitely the pinhole will drop the vision immediately. And if it's only corneal high astigmatism or distortion, definitely pinhole will give better vision.
So
Also,
this
I do this in the
is a
clinic.
topic at a course that myself and Drs. Walter Stark and Sandeep Jain and Chris Rapowano and a couple of other people who joined us for the course for 20 years, 20 consecutive years. We talk about using the excimer laser for phototherapeutic keratectomy techniques. And this point is always, especially for superficial conditions, you will find out that if you have, especially the excimer lasers that are not the scanning lasers, but the large area ablations, they can be a great first step. If you find out that the opacity is the problem, you approach it slightly differently than if it's a irregularity. And learning these techniques should be a tool in the hands of all surgeons who are interested in managing these conditions. At the end of the day, if it's deep, you have to do either anterior lamellar procedure or DALC. But we can't forget also about the superficial keratectomy techniques, especially using PTK.
Yeah.
Beautiful. We need just to move because we still have plenty of questions.
Go ahead.
A question from Dr. Grimm. She said, can the speakers comment about the type and doses of steroids to be used when amniotic membrane grafts were placed?
Well, do you want to comment, Dr. Dimitri?
No, I think you're more familiar. I mean, I can comment later and add if you want, but
I don't think it depends on the conditions first. If you are treating inflammatory disease or a melting disease, so you have to give steroid to treat the underlying conditions. But let's take that you are doing amniotic membrane for the region. There's not much inflammation. I don't think I taper steroid over 4 weeks, just the regular steroid like I give it for cataract procedure, or 4 to 6 weeks, it depends. But lots of lubrication and some antibiotic to cover this time of treatment, like 3 to 4 weeks till I have epithelialization. So it depends on the underlying conditions again. If the underlying conditions just like the region, no inflammation, just the regular steroid like in cataract procedure. Inflammatory conditions, it depends on the condition itself, how long it takes your steroid, or I keep the steroid for life, sometime twice a day, morning and evening, for long period. It depends on the stability of the ocular surface.
So if the question was about, I agree with Dr. Gerardi. One other comment is that for patients where there is, you're being surprised about the outcome and they're not responding, you have to think about underlying conditions. The list is huge. You have to do a battery of tests and then importantly, if you're not familiar with the use of not just oral or steroids, but anti-inflammatory medications, meaning TNF-alpha inhibitors, etc., it's good to partner with a colleague who is either a rheumatologist familiar with this or an oncologist who is using many of these drugs for management of their patients, or a kidney doctor who is also working on these. And I found, depending on the institution, you will find somebody who will be your partner in this, and they can manage the systemic condition, and often just by taking care of the systemic disease, which often require much more than steroids, much more than oral steroids, that these patients will do better on the ocular surface.
Okay, beautiful. So we'll carry on. This is a question from Dr. Arif, and he's asking the duration you can use cyclosporin in children and minimum age you can use cyclosporin. I guess he's referring to the case of Vernal.
I will leave that to Dr. Gerardi, but I tell you this, there's a question also on using cyclosporin versus liftigraft here. The issue is that we're not talking here about the 0.05% that are medications used for treatment of dry eye. We're talking about heavy duty 2% cyclosporin that's prepared in a pharmacy.
The same. Well, here I titrate concentration. It depends on the age. Definitely younger age, I don't go for a high concentration. And I try to keep minimal concentration. But I think the eye drops cyclosporin, I don't think they are much permanent or going to affect the health of the patient by the eye drops. Maybe we are giving very, very minimal concentration, 0.2 the maximum, or 0.1 or 0.05, etc. So again, I give in pediatric, I give in pediatric cyclosporine in fulminant case of allergy. Yes, they help a lot. I keep them for months and months, sometimes year. I tried the minimal concentration to control 0.1, sometimes 0.05, sometimes 0.2. I put maintenance dose sometimes twice daily or 3 times a day. It depends on the severity of the disease and in the age. Definitely, the younger, the lower concentration I go, and with the combined with steroid and antihistamine, etc. But they work quite good, cyclosporine.
But I think as you go, as both of you mentioned, I think you are referring more to 1% and not 0.1%. 1
Okay.
or 2%, correct?
Yeah, exactly. 1%.
0.1 per thousand, yes.
Yes. Okay, beautiful.
Then, we are now past midnight your time. If you want to ask the last question.
Well, last question, and then we will stop it there in respect to Dr. Shabir. He's asking about role of vitamin D medication and the management of dry eyes.
I can answer. Vitamin D has been shown to be effective in many conditions. We've done a lot of work early on with probably the vitamin D expert at Boston University, who ran multiple treatments for multiple conditions, and it turns out wherever you use vitamin D, we're talking about here oral medication vitamin D, it seems to be helpful. We did some animal experiments, reviewed the literature recently. It has benefits in many of these connective tissue diseases, etc. But it's always marginal, like, yeah, it helps a little bit. So there it becomes like a cult. Now, he may be referring also to vitamin A, where it is clearly something that has been a very clear topic in dry eye disease. And Schaefer-Sang was the first to really focus on this. And we all find a role for vitamin A in patients who have dry eye and vitamin A deficiency. So that's something that you have to keep in mind in some patients. And I think like the same that child that Dr. Jaradi showed with the decreased corneal sensation as a result of dry eye. Some patients maybe, if they have poor nutrition, alcoholics, people homeless, you will find a high incidence of vitamin A deficiency, and associated with it, there will be Bitot spots and corneal dry eye disease. And in these patients, replacement therapy for the missing vitamin A would be useful.
Well, the same question applies for the omega compound. You know, we used to believe that omega is having good effect, omega fatty acid, but we didn't continue it. Why?
There was a paper published in the New England Journal of Medicine not too long ago by the group from initially from New York and later from Louisiana, LSU, showing that when they did a controlled trial, it turns out they were not able to show any differences between the control and the treatment group with the omega treatments. The people are criticizing this paper, I think unfairly, because the controls received some olive oil, just like a teaspoon or something like that, that many of you would be eating in your daily diets. So we know if you're having olive oil and you add these things, it's not going to help. But if your diet has no olive oil in it, then maybe there is a potential benefit there.
So we better stop olive oil to get benefit from olive oil.
Beautiful. Thank you, Dr. Dimitri Yazar and Dr. Elias Jorada for this wonderful webinar. On behalf of the Emirates Society of Ophthalmology, on behalf of all the colleagues attended tonight, I would like to thank you for this outstanding, enormous experience that you shared with us tonight. Again, I would like to thank Shuruk, Amir, and all Novartis team for setting up the platform for this webinar. And I would like to thank all the delegates who continued with us till the end of the webinar. Just the last point is the CME certificate link has been shown by Shuruk in the chat box. So if you can open it there and you can click each one, and then as we discussed earlier, within 5 to 10 minutes, you receive the email having your CME certificate. In case of any problems, Shuruk will have her email shown there to follow up with you in case of any problems with that.
Dr.
Thanks a lot.
Saleh, one last point. As you know, I'm on the board of the Tear Film and Ocular Surface Society, TFOS, and on behalf of TFOS, this is the first session that's focusing on dry eye here. We want to thank you again for your leadership in this, and thank the Emirates Society of Ophthalmology. And personally, I felt great working with Elias. You can imagine all these lab meetings for 2 years in Boston, arguing with each other and helping each other. He was, an amazing person and continues to be. And the Middle East is lucky to have Elias doing all this good work. And I'm sitting in San Francisco now, enjoying the sun and making comments from a distance.
I would say thank you, Dimitri, thank you, everyone. It's very nice, but without pizza.
Yeah, we call them pizza rounds. We should I have resumed the pizza rounds until about 3 years ago, and that's why I've been adding weight. And you look slim, Elias.
Yeah, because I stopped pizza.
Okay, bye-bye, everyone.
Bye-bye. Thank you.
Okay.
Thanks a lot for everyone.
Good night. Good night, everyone. Sorry, keep you away.
Thank you, doctors. Thanks a lot. Have a great night.
Bye-bye.
Thanks for being.
Thank you, Shuru. Bye-bye.
Thank you. Have a great night.